Crohn's disease is a chronic, relapsing, remitting, non-infectious inflammatory disease of the gastrointestinal tract. The inflammation involves discrete parts of the gastrointestinal tract, anywhere from the mouth to the anus. These are called skip lesions because they leave normal areas in between. The full thickness of the intestinal wall is inflamed, in contrast to the inflammation in ulcerative colitis, which is limited to the intestinal mucosa. In a population-based study, N306, Crohn's disease was located in the terminal ileum in 45%, colon in 32%, ileocolon in 19%, and upper gastrointestinal tract in 4% of people. Extraintestinal manifestations, including abnormalities of the joints, eyes, liver, and skin, have been reported in more than 6% of people with Crohn's disease, especially people with colonic Crohn's disease. Crohn's disease and ulcerative colitis are collectively known as inflammatory bowel disease. In about 5% of people, it is not possible to differentiate histologically between Crohn's disease and ulcerative colitis, and the term inflammatory bowel disease type unclassified, previously known as indeterminate colitis, may be used. Crohn's disease is classified into mild, moderate, or severe disease, although these categories are not precisely defined. The Crohn's Disease Activity Index classifies active disease as a score greater than 150, with severe disease greater than 300. NICE defines severe active CD as very poor general health with one or more of weight loss, fever, severe abdominal pain, and frequent, 3 to 4 per day, diarrheal stools present. Causes and risk factors. The causes of Crohn's disease are widely debated, and no factor has consistently met the criteria necessary to be recognized as the sole or major cause of the condition. It is thought to be an immune-mediated condition caused by environmental triggering events in genetically susceptible people. Factors that are likely to play some role in the development of the disease include family history. A family history of Crohn's disease is present in about 25 to 40% of children. And siblings of a person with Crohn's disease are 17 to 35 times more likely to develop the condition than the general population. Smoking. The risk of Crohn's disease is increased in smokers, in contrast to ulcerative colitis, where the risk is decreased. A meta-analysis found the odds ratio for the risk of Crohn's disease in smokers compared with non-smokers to be 1.76. In addition, smoking may increase the risk of disease relapse and need for surgical resection. Infectious gastroenteritis. The risk of Crohn's disease is increased fourfold following an episode of infectious gastroenteritis, particularly in the following year. However, the absolute risk is low. Appendicectomy. The risk of Crohn's disease increases early after an appendicectomy and decreases to that of the general population after about 5 years post-operatively. A meta-analysis found that the relative risk of Crohn's disease within a year post-appendicectomy was 6.7, and after 5 years, the relative risk was 1.1. Subsequent research, however, has found conflicting evidence for this association, which may be related to diagnostic difficulties in detecting Crohn's disease in these people. Drugs. Non-steroidal anti-inflammatory drugs, NSAIDs, may increase the risk of relapse or exacerbation of inflammatory bowel disease, IBD, but the absolute risk is low. The risk of IBD may be increased in women using oral contraceptive drugs. A meta-analysis of 14 studies, N75, 815 of people with IBD, found that the pooled relative risk for Crohn's disease for women currently using an oral contraceptive was 146. Complications of Crohn's disease include psychosocial impact, for example on school, work, or leisure activities. Intestinal complications, including intestinal strictures, where the intestine narrows and partially or completely obstructs the passage of bowel contents. Fistulas, where the bowel wall is perforated, allowing fecal matter to track through to adjacent organs, such as the intestine, bladder, vagina, abdominal wall, or perianal skin. Fistulae develop in about 1/4 of people with Crohn's disease. Perianal disease, a frequent complication of colonic and ileocolonic disease, characterized by fissures, fistulae, or abscesses. Acute dilation and perforation of the gastrointestinal tract. Significant hemorrhage, especially if the disease affects the colon. Anemia, due to iron deficiency, through blood loss or nutritional deficiency. Vitamin B12 or folate deficiency, through decreased absorption, or anemia of chronic disease. Malnutrition, faltering growth, and delayed pubertal development in children may be due to reduced oral intake, increased nutrient requirements, increased gastrointestinal losses and malabsorption, chronic corticosteroid use, and drug-nutrient interactions. Cancer. There is evidence of an increase in the incidence of cancer of the small and large intestine in people with Crohn's disease. Extraintestinal manifestations are more common in people with Crohn's colitis compared with other areas of gastrointestinal tract involvement. Be aware that extraintestinal manifestations may present before gastrointestinal symptoms become prominent. Extraintestinal manifestations related to disease activity include poikiarticular arthritis. This affects fewer than 5 large joints, such as the ankles, knees, hips, wrists, elbows, and shoulders. It is the most common extraintestinal manifestation of inflammatory bowel disease, IBD, and affects 10–35% of people with Crohn's disease. It is usually asymmetric, acute, and self-limiting, lasting for weeks rather than months, and joints tend not to be permanently damaged. There is often associated enthesitis, inflammation where a tendon attaches to a bone, tenosynovitis, inflammation of a tendon and its sheath, or dactylitis, inflammation of an entire finger or toe. Erythema nodosum tender, red or violet subcutaneous nodules, 1–5 centimeters in diameter. Usually on the anterior tibial area or extensor surfaces of the legs or arms. Aphthous mouth ulcers, painful, clearly defined, round or ovoid. Shallow ulcers of the smooth surfaces of the mouth and underside of the tongue. Episcleritis red eye with injected sclera and conjunctiva. May be painless or painful, itching or burning. Metabolic bone disease, osteopenia, osteoporosis, osteomalacia, osteoporosis occurs in up to 30% of men and women with IBD. Contributing factors include age, corticosteroid treatment, smoking status, low physical activity, extensive small bowel disease or resection, and nutritional deficiencies. Extraintestinal manifestations not related to disease activity include axial arthritis. This affects the sacroiliac joint, sacroiliitis or spine, spondylitis, causing buttock and back pain. Polyarticular arthritis. This affects 5 or more joints, such as the small joints of the hands. It is usually symmetrical and persistent, and it damages the affected joints. Pyoderma gangrenosum single or multiple erythematous papules or pustules develop into deep ulcers containing sterile pus, unless they are secondarily infected. Occurs anywhere, most commonly on the shins, and often at the site of previous trauma. Psoriasis, the systemic, immune-mediated, inflammatory skin disease, which typically has a chronic, relapsing, remitting course, and may have nail and joint involvement. Uveitis, also known as iritis or iridocyclitis. Uveitis is usually bilateral, with an insidious onset and chronic course. It presents as a painful red eye, with injected conjunctiva, blurred vision, photophobia, and headache. Hepatobiliary conditions, such as primary sclerosing cholangitis, pericholangitis, steatosis, autoimmune hepatitis, cirrhosis, and gallstones. They often present as an incidental finding of abnormal liver function tests, rather than as biliary symptoms. Primary sclerosing cholangitis can progress to cirrhosis and increases the risk of cancers of the bile duct, colon, and rectum. Others rare extraintestinal manifestations of inflammatory bowel disease include bronchiectasis, bronchitis, hyperhomocystinemia, pancreatitis, renal stones, and venous thromboembolism. The diagnosis of Crohn's disease may be difficult as it has unpredictable relapses and remissions, and clinical features vary with age. onset, insidious, or acute. The site of disease and the presence or absence of complications and extraintestinal manifestations. Suspect Crohn's disease in people with otherwise unexplained persistent diarrhea, frequent loose stools for more than 4 or 6 weeks, including nocturnal diarrhea. In Crohn's colitis, there may be fecal urgency, tenesmus, the desire to defecate while passing little or no stool, and blood or mucus in the stool. Abdominal pain or discomfort. This may be due to adhesions, fistulas, intestinal obstruction or dilatation, or mucosal inflammation with active Crohn's disease. Nonspecific symptoms, such as fatigue, malaise, anorexia, or fever. On examination, there may be pallor, clubbing, aphthous mouth ulcers, abdominal tenderness or mass, for example in the right lower quadrant, perianal pain or tenderness, anal or perianal skin tag, fissure, fistula, or abscess, signs of malnutrition and malabsorption, serial weight loss, or, in children, faltering growth or delayed puberty. Extraintestinal manifestations, including abnormalities of the joints, eyes, liver, and skin. Suspect a complication of Crohn's disease if there is a history of recurrent urinary tract infections and passing gas or feces in the urine. May suggest a fistula allowing fecal leakage into the bladder. A history of passing gas or feces through the vagina may suggest a fistula allowing fecal leakage into the vagina. Perianal discharge of mucus or pus may suggest a fistula allowing fecal leakage through the perianal skin. Partial bowel obstruction, abdominal colicky pain and distension, diarrhea due to stasis of bowel contents and bacterial overgrowth, or complete bowel obstruction, severe abdominal pain, vomiting. Nephritis and complete constipation may suggest intestinal stricture. If a diagnosis of Crohn's disease is suspected, consider arranging the following investigations in primary care, depending on local availability. Serum full blood count. Anemia may be due to blood loss, malabsorption, or malnutrition. An increased platelet count may suggest active inflammation. Serum inflammatory markers such as C-reactive protein and erythrocyte sedimentation rate may be raised if there is active inflammation or an infectious complication. Serum urea and electrolytes to assess for electrolyte disturbance and signs of dehydration. Serum liver function tests, including albumin. A low serum albumin, they indicate protein-losing enteropathy. Serum ferritin, vitamin B12, folate, and vitamin D levels may be nutritional deficiencies due to malabsorption or intestinal losses. Celiac serology to exclude celiac disease. Stool microscopy in culture, including Clostridium difficile toxin, to exclude infective gastroenteritis or stool membranous colitis. Note: the diagnosis of a pathogen does not exclude a diagnosis of Crohn's disease, as the first episode may be triggered by enteric infection. Fecal calprotectin, a fecal white cell marker, for adults, if raised, may suggest active inflammation, compared with a normal result which is expected in irritable bowel syndrome. Note that investigation results may be normal in a person with active Crohn's disease. Differential diagnosis. Alternative conditions which may present similarly to Crohn's disease include ulcerative colitis, infective colitis, pseudomembranous colitis, Clostridium difficile infection, microscopic colitis. This typically presents with chronic watery diarrhea in older people and may be associated with the use of drugs such as lansoprazole, aspirin, sertraline, ranitidine, and simvastatin. Intestinal ischemia. This typically presents with sudden onset abdominal pain, which is disproportionate to clinical findings, with possible signs of an acute abdomen, such as abdominal distension and guarding. Symptoms may be associated with eating. It occurs when colonic perfusion is impaired, for example by mesenteric artery emboli, arterial or venous thrombosis, or vasculitis. Acute appendicitis. Acute terminal ileum disease can mimic acute appendicitis, diverticulitis, celiac disease, irritable bowel syndrome, anal fissure, malignancy such as colorectal cancer, small bowel cancer, and lymphoma, endometriosis, laxative misuse. Management of Crohn's disease. Urgent hospital admission for a patient known to have Crohn's disease is required if there is severe abdominal pain, especially if there is tenderness on palpation. There is severe diarrhea, frequency 8 or more times per day, with or without rectal bleeding. There is bowel obstruction. The patient has fever and is systemically unwell. If the patient does not require admission, assess disease activity by thorough history and examination and blood tests, FBC, CRP, renal function, and electrolytes, LFTs. Prompt referral is indicated for any patient with rectal bleeding and abdominal pain, change in bowel habit, weight loss, or iron deficiency anemia. Cancer pathway referral should be strongly considered, as fecal calprotectin is not sensitive enough in the exclusion of advanced colorectal adenoma or colorectal carcinoma. This is especially the case in over 50, while these symptoms in patients under 50 years are strongly predictive of IBD or colorectal cancer, but generally don't discriminate between the two. IBD is significantly more common in younger age groups. Inducing remission in Crohn's. Monotherapy. Offer monotherapy with a conventional glucocorticosteroid, prednisolone, methylprednisolone, or intravenous hydrocortisone to induce remission in people with a first presentation or a single inflammatory exacerbation of Crohn's disease in a 12-month period. Consider enteral nutrition as an alternative to a conventional glucocorticosteroid to induce remission for children in whom there is concern about growth or side effects, and young people in whom there is concern about growth. In people with one or more of distal ileal, ileocecal, or right-sided colonic disease, who decline, cannot tolerate, or in whom a conventional glucocorticosteroid is contraindicated. Consider budesonide for a first presentation or a single inflammatory exacerbation in the 12-month period. Budesonide is less effective than a conventional glucocorticosteroid, but may have fewer side effects. In people who decline, cannot tolerate, or in whom glucocorticosteroid treatment is contraindicated, consider 5-aminosalicylate 5-ASA treatment for a first presentation or a single inflammatory exacerbation in a 12-month period. 5-ASA is less effective than a conventional glucocorticosteroid or budesonide, but may have fewer side effects than a conventional glucocorticosteroid. Do not offer budesonide or 5-ASA treatment for severe presentations or exacerbations. Do not offer azathioprine, mercaptopurine, or methotrexate as monotherapy to induce remission. Add-on treatment. Consider adding azathioprine or mercaptopurine to a conventional glucocorticosteroid or budesonide to induce remission of Crohn's disease if there are 2 or more inflammatory exacerbations in a 12-month period, or the glucocorticosteroid dose cannot be tapered. Assess thiopurine methyltransferase TPMT activity before offering azathioprine or mercaptopurine. Do not offer azathioprine or mercaptopurine if TPMT activity is deficient, very low, or absent. Consider azathioprine or mercaptopurine at a lower dose if TPMT activity is below normal but not deficient. Consider adding methotrexate to a conventional glucocorticosteroid or budesonide to induce remission in people who cannot tolerate azathioprine or mercaptopurine, or in whom TPMT activity is deficient, if there are 2 or more inflammatory exacerbations in a 12-month period, or the glucocorticosteroid dose cannot be tapered. Infliximab and adalimumab. Infliximab and adalimumab block the action of the cytokine tumor necrosis factor alpha, which mediates inflammation in Crohn's disease. Infliximab or adalimumab is recommended by NICE for the treatment of severe active Crohn's disease that has not responded to conventional therapy, including corticosteroids and other drugs affecting the immune response, or when conventional therapy cannot be used because of intolerance or contraindications. Treatment should normally be started with the least expensive drug in this class. Patients starting this treatment should be offered advice about the option of monotherapy with infliximab and adalim. UMAB or combination therapy with an immunosuppressor. Essent. Infliximab is recommended for the treatment of fistulating Crohn's disease that has not responded to conventional therapy, including antibacterials, drainage, and other drugs affecting the immune response, or when conventional therapy cannot be used because of intolerance or contraindication. Infliximab or adalimumab should be given as a planned course of treatment for 12 months or until treatment failure, whichever is shorter. Treatment should be continued beyond 12 months only if there is evidence of active disease. The need for treatment should then be reviewed at least annually. If the disease relapses after stopping treatment, adalimumab or infliximab can be restarted. Adalimumab is recommended by NICE as an option for treating moderately to severely active Crohn's disease only if a TNF-alpha inhibitor has failed or a TNF-alpha inhibitor cannot be tolerated or is contraindicated. Ustekinumab is recommended by NICE as an option for treating moderately to severely active Crohn's disease in patients who have failed to respond adequately to, were intolerant of, or have contraindications to conventional therapy or a TNF-alpha inhibitor. Maintaining remission in Crohn's. Smoking cessation is very important. Offer azathioprine or mercaptopurine as monotherapy to maintain remission when previously used with a conventional glucocorticosteroid or budesonide to induce remission. Also consider azathioprine or mercaptopurine to maintain remission in people who have not previously received these drugs, particularly those with adverse prognostic factors such as early age of onset, perianal disease, glucocorticosteroid use at presentation, and severe presentations. Consider methotrexate to maintain remission only in people who needed methotrexate to induce remission, or have tried but did not tolerate azathioprine or mercaptopurine for maintenance, or have contraindications to azathioprine or mercaptopurine. Do not offer a conventional glucocorticosteroid or budesonide to maintain remission. Surgery. Crohn's disease limited to the distal ileum. Consider surgery as an alternative to medical treatment early in the course of the disease for people whose disease is limited to the distal ileum. Consider surgery early in the course of the disease or before or early in puberty for children and young people whose disease is limited to the distal ileum and who have growth impairment despite optimal medical treatment. T and/or refractory disease. Managing strictures. Consider balloon dilation, particularly in people with a single stricture that is short, straight, and accessible by colonoscopy. Ensure that abdominal surgery is available for managing complications or failure of balloon dilation. Maintaining remission in Crohn's disease after surgery in patients who have had complete macroscopic resection within the last 3 months. Consider azathioprine in combination with up to 3 months postoperative metronidazole. If metronidazole is not tolerated, consider azathioprine alone. The effects of azathioprine and metronidazole should be monitored, including monitoring for the neutropenia for all people on azathioprine. Biologics should not be offered to maintain remission after complete macroscopic resection of ileocolonic Crohn's disease. People who started biologics before May 2019 should continue on treatment until they and their healthcare professional agree that change is appropriate. Budesonide should not be offered to people with ileocolonic Crohn's disease who have had complete macroscopic resection to maintain remission. Management of Crohn's complications. Fistulating Crohn's disease. Treatment may not be necessary for simple, asymptomatic perianal fistulas. Metronidazole or ciprofloxacin can improve symptoms of fistulating Crohn's disease, but complete healing is rare. Other antibacterials should be given if specifically indicated, such as for sepsis associated with fistulas and perianal disease, and for managing bacterial overgrowth in the small bowel. Fistulas may also require surgical exploration and local drainage. Either azathioprine or mercaptopurine can be used as a second-line treatment for fistulating Crohn's disease and continued for maintenance. Infliximab can be used for fistulating Crohn's disease refractory to conventional treatments. Adalimumab can be used if there is intolerance to infliximab. Treatment of extraintestinal manifestations. Oral Crohn's disease, topical steroids, topical tacrolimus, intralesional steroid injections. Enteral nutrition and infliximab may have a role in management, but there are no randomized controlled trials. Arthritis and arthropathy. There is some general support for use of sulfasalazine, simple analgesics, local corticosteroid injections, and physiotherapy. In axial arthritis, the arguments in favor of intensive physiotherapy, sulfasalazine, methotrexate, or infliximab are somewhat stronger. Erythema nodosum, systemic corticosteroids are usually required. Pyoderma gangrenosum, topical and systemic corticosteroids, with the more toxic cyclosporin and tacrolimus reserved for resistant cases. Data support the use of infliximab. Episcleritis may not require specific treatment, but will usually respond to topical corticosteroids. Uveitis is treated with topical and/or systemic corticosteroids. Primary sclerosing cholangitis responds to ursodeoxycholic acid. Endoscopic retrograde cholangiopancreatography may be used to treat dominant strictures by dilatation and/or stenting. Advanced liver disease may necessitate transplantation.